go.
Hello, Jim Adams here again. Now we're going to be doing a dressing change on a wound. Now, different types of wounds, surgical wounds that may be dehisced. There are decubitus ulcers. Anyway, all kinds of wounds. The one we're going to do is on the coccyx, and it's going to be a normal saline, wet to dry. There are other type of solutions you might use. There's Dakin's wet to dry. Back in the day, I've done betadine wet to dry. So there are other types. You got to make sure what the order says. So, as I always do when I'm in the sim lab and at work, I always, number one, check my order. We want to make sure we've got the right patient. So as I walk in the room, I would wash my hands. I would check my patient's wristband. Although this patient really doesn't have a wrist, I don't even think the ICU at MICU could save this one because he's not even a full torso. But anyway, this is sim lab, so we don't have to worry about actual patient survival. So I would check a wristband. I would ensure adequate lighting. I would provide patient privacy, and I would get my room ready. Now, one thing you want to have available is a trash can because you're going to be pulling off old dressings and whatnot. And I'm not really going to use a trash can because this is a sim lab. And if you throw away your stuff out of your pack, you're either going to be having to buy more stuff or pick up out of the dirty trash can. So we're just going to simulate a trash can here, and that'll be my trash can. Now, I'm going to make sure I have all of my equipment available. I have clean gloves, sterile gloves, ABD pad. I have 4x4s. I have my saline, and you better read it because sometimes at the bedside there might be sterile water. It's always best to use saline in these when it's ordered saline. So, I'm going to want to measure the wound. You can use one of these things, or you can use an actual, what is this, a ruler. So, when you're thinking about wounds also, there's some terminology you're going to need to know. Stage 1, Stage 2, Stage 3, Stage 4. Stage 1 is a blister. Stage 2 is when the blister comes off and you got open tissue. Stage 3 is into the muscle, and Stage 4 is down to the bone. I've also seen it down through the bone. We have little cards for you. This may be something you'll see on a test, so make sure you know this terminology. Purulent drainage, serosanguinous, sanguinous. These are all terms you're going to vocabulary terms you're going to need to know. So once again, I got my hair pulled back, my sleeves up, and I am ready to go. So, I think before I put on my gloves, actually I'm going to get my equipment ready to use. So, I'm going to open my saline. I'm going to put a sterile needle on my syringe, and I'm going to use that to draw up my saline. This is for my irrigation. Now notice, when you recap, you're going to get in trouble in your clinical area. Although this is a sterile needle, you want to recap the proper way. On the edge, I guess I need to turn this around so you can see it. On the edge, it's over the edge, so I know that it's sterile. That's the only safe way to cap a sterile needle. Now, if you're ever in the clinical area and you're giving the patient a shot and you go to cap a needle anyway, they could and probably should send you home with the unsacked clinical day because that's been in a patient and it's not a sterile needle, it's a dirty needle. You need to hold that up, take it to the sharps container, and throw it away. Don't recap, even if you're using the scoop method, don't recap a dirty needle. only recap a sterile needle. And this is how you actually do it. And notice I'm not grabbing it like this and pushing it down. What if you got it cockeyed and it poked through? So the way I do it is once I grab it down low, below the needle. Just an FYI, so here we go. So I've got my irrigation stuff ready to go. Now I'm going to get my actual wet to dry things ready. So these are my gloves I'm going to use. And I like to utilize multiple areas because this is such a little table. I can just get all, I can get totally cramped up here and not have enough space to do what I need. So I like to have enough room to do what I need to do. So I'm going to open my ABD pad. And this is like a sterile procedure, and I'm making a little teensy sterile field here. My hands are clean, but which really means dirty, so I'm going to just set this here, its own little sterile field. And I like to so that I know what I'm doing, I like to ensure all my stuff's going to remain in my little sterile fields. I'm not in a hurry because my patient has not been touched yet. Now notice how I've told you, well, if you forget to say something, do something, you got to say it. You can't just breeze by it because I'm going to know. The first thing I should have said, after I verified that it's the right patient and check their wristband and whatnot, I should have said, I'm going to get this patient some pain medicine because I want to give it some time to work before I actually start touching the patient. Because you want to have your patient medicated before this because it can be painful. If you got something down through the nerves like maybe a deep stage 3 or stage 4, it might not hurt except at the edges a little bit, but you always want to have some pain meds on board before you do your dressing change. So always say I'm going to pre-medicate my patient before a dressing change. So now I am ready to do my, and that's the thing about simulating this stuff. I'm not really going to get anything wet, but you can forget a step because, you're not actually doing every single thing, but I need to have my gauzes wet, so I'm going to open this up, pour some saline, pour some saline. Now we're ready to actually start touching the patient. So I'm going to put on my clean gloves because normally this patient's going to have a old dressing on. I have walked into rooms and maybe they rubbed it off and it's actually laying in the bed and their wound's just touching the bed. You never know what you're going to find. So I always like to have gloves on, and I'm going to check my patient. And they do have a wound in a dressing on. Now when I look at this mannequin, just kind of like a FYI for you all, when you do look at the mannequins, whoops, we have a stage 1 here because it's like a blister. It's not actually open tissue. Stage 2, where the blister came off. Stage 3, down into the muscle. And this is the stage 4 that we're getting ready to change. Over here we have a surgical wound. And that's like a bruise or hematoma. And here, this black, if you have a wound that's got black stuff on it or a heavy coating which you can't really see down into, you can't stage it, so it's called unstageable. So just kind of an overview there. Now as I'm getting ready to touch my patient and do all my stuff, I'm going to raise the bed to a working level. Because it would be hard on my back stooping down to do all this, so I want to get them up to my level. And if you're shorter, it won't be this high or take nearly as long to raise the bed to a working level for you. Okay, now we're going to take off the old dressing. So I'm going to kind of peel up, peel it off. And it has the old packing in there, so I'm going to pull it off. Sometimes it might actually be dried in there on the wound, and in that case, you're going to have to get some saline and spray on it to get it to come off. Like if this were packed in there, and I've seen people want to do this and spray like this. You could. I'm always afraid I'm going to jab the patient with a needle though, so I never do that. I always would spray like this a little bit. Get it moist so that I could pull it off. So now I've got these dirty gloves on that have touched that, so I'm going to take them off inside out. And now I'm going to actually irrigate the wound. So to irrigate the wound, I'm going to have the patient lay over on their side, and I'm actually going to slide everything over a little bit so that you can see. But I would have the patient lay up on their side. I would lay down a towel because I don't want to get my linens all wet, because that would just take more time having to change an occupied bed. So I'm going to take my syringe. If I hold it like this, I'm going to have them lay on there, and then I'm going to just kind of squirt this down in there, and it'll be draining out into the pan. Then I can throw this in the sharps and throw this away. So I've got the wound cleaned out. So when you come in Sim Lab, always put your phone on vibrate. So now we're ready to continue on. So I'm done with these gloves because you know, I'm going to get my sterile gloves on now. So over here on this other table, it's a flat surface I can use. I'm going to open my gloves, and always observe when I open them, if I screw up, that's going to be going off on my, that's going to be one of those things you have to be told you messed up on something. You only get one thing that I can say before you're told that you didn't pass the checkoff. And not pass the checkoff's not the end of the world. You just lose 50% of your points. Okay, I've got my sterile gloves on. Now there are times we might be doing procedures with a physician, putting in a central line or something, and I'm standing there with sterile gloves. I don't just stand there with my sterile gloves on because I could hit something. I stand there with my sterile gloves on. I want to remember they're sterile. I'm not standing there breathing on my gloves. I'm trying to keep them to the side. I don't know. That's just how I do things. Some people want to stand like this. However you want to do it, but you got sterile gloves on, so you can't be having your hands dangling around, moving around, maybe knocking on stuff. So when you got sterile gloves on, if you're just waiting for something, or however you want to do it, just know you got sterile gloves on. Make sure you don't touch anything. So I'm going to grab my wet gauze. I'm going to wring it out. I'm going to grab my other wet gauze and wring it out. I like to put them both on the same one. They're not going to flop around like they are here because they would be wet. Now I've got to get these little Q-tips out. I don't want to go touching on them or touch anything around, so what I always do is how I opened it, that should be a sterile area. And I can pull it out. I'm going to do it with this other one here so you can see it really well. I'm going to put my finger on the sterile area, and then I'm going to pull it out. Was that clear enough? Okay. Now I want these to be kind of wet, so I'm going to pick them up in one of my damp gauzes and smash it around and get them moist also. So we are getting ready to do our sterile dressing change. I've got my sterile gloves on, and once again, if I say it, it's okay. Now if the instructor has to say it, then you got a problem. Well, I'm going to tell you, I didn't measure my wound site. So what can I do to rectify this? What do? Well, you're going to contaminate your gloves, and then you're going to put new gloves on. That's why I always carry extra gloves in my pocket. So I'm going to grab this here, knowing I'm going to burn a pair of gloves, and I'm going to measure. So 7.5 by 10 centimeters, and you're going to want to measure in centimeters. So that's one way you can handle it. Get new gloves. The other way you could have handled it is you can say, you know, I didn't measure that, but what else can I do? There's lots of different ways to do things right. That's what I always tell people. Now there's a lot more ways to do it wrong, but I could have done this. So it's about, see this, I'm getting about 10.5 centimeters. And that's why I always chart approximately, because it's not an exact measurement. Plus, this would be more supple with a patient, and if they spread their leg out or something, the wound can maybe move out, the skin can move out a little bit. So it's always going to be an approximate. And then I would just try to measure this way. And I'm being careful not to get real super close, because my hands might touch. So you always want to leave an inch or two. And I just kind of, and then just kind of, and see there, I'm seeing about 7.5. So anyway, that's why I always chart approximate. So I've got a measurement for the size of the wound, 10.5 by 7.5. Now I'm going to check the wound for any tunneling and whatnot. Now I'm looking at the patient. Notice there, how am I going to say where all this stuff is in this wound? Well, this is 12 o'clock. The top of the patient's 12 o'clock. So it's from there. So I'm going to start at 12 o'clock. Okay, so we got some tunneling there. And I would say that's about 1.5 centimeters. I'm just looking where it goes on that cotton swab. So the 1.5 centimeters is going pretty much to from about 12 o'clock to about 1 o'clock, we'll say. And then the tunneling gets narrower and narrower, shallow, more and more shallow, I guess I should say. And then it's nothing. Now I can see this tunnel here. Now notice I'm not going all the way to the edge and touching the edge of his skin, because that could be contaminated and I got on sterile gloves. So I'm going to get close and see about how close that is. Once again, I'm just going to give an approximate number. And so that's about 2.5 centimeters. So at 7 o'clock, 2.5 centimeters. Shallow, shallow, nothing. And then it starts again, the tunneling starts again around 11 o'clock. Okay, so this towing that goes 1.5 centimeters is about 11 o'clock to about, I'm just going to say 1 o'clock. There's another tunnel, 2.5 centimeters at 7 o'clock. Also, when I look at this in the very middle, I see white bone. That's what makes this a stage 4. And we also have an area at 5 o'clock that's unstageable, black necrotic tissue. So those are the dimensions I need. I'm also wanting to see about a depth, but that's a little harder to get, and that's a little more of an estimate. But I'm just going to just touch the deepest part and go about where the contour says the skin would be if it was there. And I'm going to say that's about 3 centimeters. So at the deepest, it's about 3 centimeters. Now this has touched all that stuff, so I'm going to throw it away, and we're going to move on. So I'm going to pack the wound. Now wound packing is a lot easier with actual wet gauze. But that's okay, we all understand it. So I'm going to take I like to just kind of twist mine because I'm going to want to pack it down into the areas that are tunnels. I'm going to gently pack it down in there as best I can. Okay. I'll just wring it out a little bit more. And I always like to, once I wring it out, I like to fluff it all out because it's a wet to dry. So I want this stuff, what this is for is when this packing starts to dry, it pulls up through capillary refill all of the bacteria and debris and whatnot that's in there. And then I will pull it out with this, when I'm doing the dressing change. So I'm going to try to get what I can up under there. And like I said, it's a lot easier when your gauze is actually wet, but we cannot use wet gauze because it hurts the mannequins. And if stuff kind of flops out, hey, we all understand because we've all done this. So I don't really need this anymore because now I'm not packing. I've got all the areas packed. I'm just going to take one more wet one, fluff it out, and just kind of stuff it on top here. And then I've got my dry gauze pad. I'm going to put it over top of it. And then I'm going to take my ABD pad and put over it. And I'm going to secure it with tape. Some dressing change kits come with their own little thing of tape, if your facility actually has a kit. And the problem you come into sometimes is the wound is not sacrum, but it's coccyx, so it's down lower, and you're having trouble with the keeping the dressing away from the anus. So that's a problem depending on where your wound is. So what I'm going to do here is I'm going to go in the middle and push down the middle first, and then kind of go out on the edges of my tape so that it'll hold it down. I would take the top. So that's it. We have done a dressing change. I would grab my gear, throw it all away, remove my gloves. And now I've got to chart. So you have to chart the size of the wound, all of the tunneling and whatnot. So I'm going to say the wound is 10.5 centimeters by 7.5 centimeters ovoid. There is a 1.5 centimeter tunneling from approximately 11 o'clock to 1 o'clock with 2.5 centimeters of tunneling at 7 o'clock and an area unstageable at 5 o'clock, irregular border. And back when we did paper charting, I'd actually draw a picture of it. Now we're computer and I can't really draw a picture of it. I would talk about how there was bone visible. The area was pink, red, moist, with some, I believe it was yellow exudate at about 5 o'clock. And I think that's about it. So remember, it's not just doing the dressing change. You got to remember all this stuff you're saying. You can't really write it down unless you have a student nurse with you or somebody that has a pen. But you're doing this in these sterile gloves. You're not going to be writing stuff down. You got to remember it. That's why look at your wound, and as soon as you get done, then you start writing this stuff down so you can go chart it. Hope there's no questions, because this is just a video and I can't answer them.